I am very pleased to introduce Dr. Sarah Wild from the University of Edinburgh in Scotland. And while I wish we can do this meeting in person, one perk of Zoom Grand Rounds is that we can more easily host international speakers. And I became familiar with Dr. Wild through her work related to diabetes and cancer epidemiology. Dr. Wild is a professor of epidemiology at the University of Edinburgh. She did her medical training in London and Cambridge in the areas of general medicine, diabetes, and public health medicine. She then completed her PhD at the London School of Hygiene and Tropical Medicine and completed a cardiovascular epidemiology fellowship at Stanford. Of note, Dr. Wild is a consultant in public health at Lothian National Health Services Board, which is the UK's second largest health system. She's also a member of the World Health Organization group on diabetes diagnosis and classification. She has authored over 300 publications. One of her main interests is the use of cutting-edge epidemiology techniques to understand diabetes risk factors and complications. And through her work, Dr. Wild has made a meaningful impact in understanding worldwide trends in diabetes and cardiovascular disease. I'm very excited to hear Dr. Wild's talk on changing trends in diabetes and its complications.
Thank you very much. And I'm just get my slides up. Thank you very much for the invitation to join you. I'm honoured to have the opportunity to share my work with you. So I shall just get this working. There we go. So as Amanda said, I'm an epidemiologist now. I started off in clinical medicine. I'm horrified to work out more than 30 years ago. So when I talk about some of the time trends in diabetes and some of the changing patterns of diabetes, I've seen many of those during my career. So what I'm planning to do in this talk is to cover these areas. We were talking earlier about how we can't travel at the moment, but I'm going to try and give you a whistle-stop tour, not just of epidemiology, but international diabetes epidemiology. And I hope the speed of the presentation doesn't give you a virtual form of jet lag as I work through quite a lot of slides. So I'm going to start off then with talking about diagnostic criteria for diabetes, which of course many of you will be very familiar with. But again, this is something that's changed during my working lifetime. When I first qualified, the diagnostic criteria for diabetes were based on a fasting blood glucose. Oh, sorry, I haven't put this in US units. Started off as a higher blood glucose cut point than it is now. And then, of course, more recently, we not only have the option of adding fasting blood glucose and a 2-hour post-oral glucose tolerance test glucose, we have HbA1c as an option for diagnosing diabetes. HbA1c has huge advantages, of course, both in clinical terms and for epidemiological studies, in that a fasting sample isn't needed. But the 3 circles on the right-hand side there, ignore the numbers, but really just to illustrate the point that if you use these different diagnostic criteria, you identify different subgroups of people with diabetes. And so this is one of the challenges when we're looking at time trends in diabetes prevalence, that we have to remember, particularly when you go back in time, that different diagnostic criteria were used. And that some of the differences in time trends are related to changes in diagnostic criteria. And it seems as though, for example, that using HbA1c may well reduce the numbers of people that are diagnosed with diabetes. So some of the recent trends in apparent declines in new cases of diabetes might be related to the switch to HbA1c. And one of the other things I wanted to mention at this stage that will come up through the talk is there are lots of differences related to ethnicity and diabetes, but in relation to this section of the talk, the performance of HbA1c to diagnose diabetes is different in different ethnic groups, which adds to the complications of interpreting ethnic differences in diabetes prevalence. One of the more recent descriptions of diabetes looked into different phenotypes. We tend to think about type 1 and type 2 diabetes, and that'll be the focus of most of the rest of the talk. But at this point, I wanted to highlight the complexity of different phenotypes of diabetes. And again, I think this is one of the big changes through my working career, in that what has happened over time is that the proportion of people with type 2 diabetes who primarily have a failure of a beta cell function and insulin secretion has vastly been outweighed by people with obesity-related type 2 diabetes and insulin resistance. And of course, this changing phenotype is also relevant to risk of complications. And this is another slide to help indicate how different groups might be distinguished, different subtypes of diabetes might be distinguished. And as time passes, we get more and more information about how best to distinguish phenotypes. But clearly, using C-peptide as a measure of continuing insulin secretion is helpful, as well as the presence of antibodies to identify autoimmune diabetes. And there are rarer subtypes of diabetes, but it's particularly important to identify some of these rarer subtypes to ensure that people receive the right treatment. And certainly many of my colleagues have got particularly interested in switching people off insulin onto sulfonylureas because they have one of these rarer subtypes of diabetes. So moving on now to describing contemporary estimates of diabetes prevalence. Type 1 diabetes, about 5% of all diabetes, and about 1 in 200 people in the UK and the US have type 1 diabetes. For diagnosed type 2 diabetes, the prevalence is about 6% in the UK and 8% in the US. And as you'll be well aware, type 2 diabetes is often asymptomatic and may well be undiagnosed. And the current estimates of the proportion of type 2 diabetes that is undiagnosed is somewhere between 20 and 30% in our countries. Clearly, there are other important forms of diabetes. Gestational diabetes is something for which the incidence, again, has increased markedly over my working lifetime. There are other forms of diabetes, and I've been interested in malnutrition-related diabetes, which isn't very well described because there's very little data. This often occurs in rural African communities, and I've recently supervised a PhD student in Rwanda, and the phenotype of her diabetes patients is very different from those seen in the US or the UK. And I don't talk about it much more, but it seems as though this form of ketosis-prone diabetes or flatbush diabetes is much more common in particular populations in Africa and in African Americans. I've listed some of those other causes of diabetes, and clearly we always have to be aware of the potential for secondary diabetes due to a variety of causes. All relevant, of course, for making sure that people get the right treatment. Moving on to some more data. Now, I said I'd talk more about ethnicity. Of course, there's a diverse population in the US, people from multiple ethnic groups. It may be a bit different in the US from in the UK, but we have a very Eurocentric view where we think Europeans are normal and non-Europeans have higher prevalence. I would actually suggest that it's the other way around, that the European ancestry populations are different, are somehow protected from the obesogenic environment that we all live in. But what we see in this slide is really highlighting how non-white ethnic groups all have higher prevalence of diabetes than white ethnic groups. And again, more data from the US showing how incredibly variable diagnosed diabetes prevalence is at county level in the US. This is in preparing for this talk, it was the first time I dug out this slide, and that variation in prevalence from 1.5% to 33% is really quite striking. I mean, it's a huge country, I know, and hugely varied, but that's was a striking finding, I thought. Now moving on to world estimates of diabetes prevalence. So this is the data from the International Diabetes Federation. I was fortunate enough at the sort of junction in my career to spend 9 months at the WHO in Geneva, working on the first global burden of diabetes estimates for 2000. So that box on the left-hand side were estimates that I contributed to. And really, we had, at that stage, we had very little data for making estimates of global diabetes prevalence. I think we had data from 38 different countries that we had to extrapolate out to provide estimates for the 191 different countries in the world, by making sweeping assumptions about extrapolation of data across countries. Since then, there have been many more estimates of diabetes prevalence. So the figures in blue are the data that are up to the current date. And these estimates include both diagnosed and undiagnosed diabetes, so total diabetes prevalence as best can be estimated. And I think now for the most recent IDF estimates, the 2020 ones that are in preparation at the moment, there's data for over 100 countries, might even be more than that, 130 countries, I think. So clearly the estimates are getting better over time as we get more data from other countries. And then the figures in orange refer to projected diabetes prevalence into the future. And so these estimates are based on age and sex specific prevalence applied to population projections. And there's always much discussion about the value of these global burden estimates. As I've perhaps illustrated, they're the best estimates we've got. They're not terribly reliable, but they're the best we've got. And I have to say, in general, the people doing these estimates for diabetes anyway try and make them conservative, because even making the estimates conservative, the numbers are still shocking. So on the far right of the screen there, by 2045, there's expected to be about 700 million people in the world with diabetes. So it's not going away. Coming back to the US now, the patterns look somewhat different in that the rise over time. These data start in 2019 and end in, start in 1999 and end in 2016. And there's just been a steady increase in diagnosed diabetes and total diabetes. And it's interesting to see in the US that the proportion of undiagnosed diabetes has declined over time, perhaps with better screening and identification of people with diabetes. I'm moving now on to incidence of type 1 diabetes. And so there's very little data on prevalence of type 1 diabetes and incidence, so the rates of new cases of diabetes. There's far more data for children than there is for adults. So the estimates that go into the International Diabetes Federation Atlas are usually based on estimates in children. I've just been involved with a paper where we're trying to extrapolate out to incidence in adults, incidence and prevalence in adults. But it's one of the areas where we definitely need more data. And what we see, interestingly, with the pattern across the world is that incidence varies markedly by country. And this, I hope, is where I'd convince you that epidemiology is useful, because these differences between countries can help lead to hypotheses about why or etiology of type 1 diabetes, which of course still remains very quite elusive. So I don't know if you can see the darker orange patch in the middle of the slide there, but that's Saudi Arabia. And to my knowledge anyway, I don't think anybody has explained why the population of Saudi have a higher risk of type 1 diabetes, where neighbouring countries don't. And that Scandinavian countries and neighbouring countries with people with Scandinavian ancestry, and I'd include the US and Canada in this, have higher incidence than other countries. I'm just going to mention briefly as well some data from the UK about incidence of type 1 diabetes in children. There has been a lot of interest in time trends. There does seem to be an increase in incidence of type 1 diabetes. And again, this is useful for hypothesizing possible explanations. But to my knowledge, anyway, none of these hypotheses have been proven yet to try and explain these patterns. There's some suggestion that increasing obesity might result in earlier diagnosis of type 1 diabetes, so that sort of extra stress on the pancreas for being overweight, even amongst children. But again, the evidence is somewhat limited. Moving back to the US now, so on the left-hand side of the slide are time trends in type 1 diabetes, without really very marked trends in the US between 2003 and 2015. And the different colour lines there reflect different ethnic groups, and in contrast to type 2 diabetes, type 1 diabetes incidence is higher in white non-Hispanic groups than other ethnic groups. Whereas, as you can see on the right-hand panel of the slide, for type 2 diabetes in adolescents, there's been marked trends over time, particularly in some ethnic groups. And clearly this is really worrying. Young people who develop diabetes have a lifetime ahead of them to get complications of diabetes. And there's some evidence to suggest that type 2 diabetes in young people is particularly aggressive, and potentially has worse effects in terms of complications than type 1 diabetes developing at this age group. But I think that there are other factors that contribute to that. And I mentioned that most of the data were are from children on type 1 diabetes. But what we see in our Scottish population is that about half of the new cases of type 1 diabetes are in adults. So it's a real gap in the data. We definitely need more data on incidence of type 1 diabetes in adults, and it's an important population, obviously, for sorting out treatment. And then here we have more data on ethnicity and different forms of diabetes, and the relative contribution of type 2 diabetes and type 1 diabetes, with the different ethnic groups having different preponderance of different type 1 or type 2. Now, this is some data that Diana Maliano in Melbourne has collated, a mammoth task, as you can see, pulling together data from multiple countries. And I think probably the first indication that diabetes incidence, the numbers of new cases were declining, came from the US. but also similar data were reported from Denmark. So Diana collated these data to show that actually in many countries, diabetes incidence seems to be declining. And although, unfortunately, in many countries, the how diabetes was diagnosed, particularly whether it is diagnosed on the basis of HbA1c or glucose, was not recorded. As part of the discussion of this paper, it was concluded that HbA1c, or the change to the criteria using HbA1c for diagnosis of diabetes, probably had little impact on these declines in numbers of new cases. So it probably contributes a small amount, but there are other factors going on. And I think it remains unexplained as to why incidence is declining, particularly, as I'll show you later, when obesity prevalence is still rising. And I look forward to discussion after the talk if anybody's got any ideas. So I just thought I'd put this slide in. I'd like you to look at the bottom line here, please. So where we balance the number of new cases, the incident cases, against the number of deaths in Scotland. And then on the right, furthest bottom right box shows the surplus of cases. And this really explains why despite declining incidence, we have increasing prevalence of diabetes, because fortunately death rates and numbers of people with death rates are declining. So this sort of balance of new cases coming in outweighs people leaving the diabetes population through death. I'm quite sure for this audience, I don't need to go through risk factors for diabetes. I've discussed already the challenges of trying to identify causes for type 1 diabetes. The best view we seem to have at the moment that it's a combined effect of environmental factors on genetically susceptible individuals. Really interesting suggestions about the hygiene hypothesis, that perhaps we're all getting far too clean at the moment. It'll be really interesting to see what the effect of COVID and everybody washing their hands more and avoiding contact with other people and spreading infectious agents will have on type 1 diabetes incidence. And then moving on to type 2 diabetes, there's a long list of factors that have been associated with type 2 diabetes. And clearly, the most obvious one is age. Increasing age is the strongest risk factor for type 2 diabetes. In most populations, risk of type 2 diabetes is higher in men than women. And the exceptions to that are perhaps in some countries where the patterns of obesity differ by sex, where, for example, in some Caribbean countries, the men tend to be thin and the women tend to be overweight. Perhaps in some Middle Eastern countries as well, where there's a starker difference in obesity prevalence. In those countries, then female prevalence of type 2 diabetes is higher in men. I've mentioned ethnicity already, and I'm going to talk more about obesity. Family history of diabetes is important, and again, I'll talk about genetics later on. One of the important factors are about increasing incidence of gestational diabetes, as I'm sure you're all well aware, is that a history of gestational diabetes is a strong risk factor for subsequent type 2 diabetes. And in some ways, pregnancy can be seen as a bit of a stress test for glucose tolerance. And so gestational diabetes is a marker of higher risk of subsequent diabetes. And I mentioned some of the psychiatric factors at the end of the list there, partly because in recent years I've become very interested in the comorbidity between diabetes and mental health. I said I mentioned genetic factors. You'll be well aware that there's been a lot of interest in trying to identify genetic factors for type 2 diabetes. The heritability estimate, so the proportion that's thought to be due to common factors with your parents, is huge range between 25 and 80%. And one of the things that I've still yet to sort out is how you separate out the genetic factors of heritability from a common familial environment. But some more data there on the genetic factors indicating that there is an important contribution of genetic factors is that if you have one parent with type 2 diabetes, your lifetime risk yourself is 40%. If you have both parents with type 2 diabetes, your lifetime risk is 70%. And then twin studies, of course, are a really useful way for investigating genetic factors. And the concordance is 70% in monozygotic twins or identical twins, and only 20 to 30% in non-identical twins. But so although I acknowledge genetic factors are important in risk of diabetes, clearly changes in genetic factors don't influence the changes that I've seen in diabetes prevalence and phenotypes over my lifetime. And I would maintain that the trends in obesity are the biggest contributor to changing prevalence of diabetes. And so this slide has got information on a range of countries on time trends in obesity, including some projections, and that box I've put there is data for the UK, or it's actually for England, showing that the projections were actually pretty accurate. So we tend to think in the UK that we're about 10 years behind the US, and in many factors, and we remain about 10 years behind you in obesity prevalence. So I mentioned previously that it remains unexplained why we see these trends in obesity, but not a similar pattern in increasing incidence of type 2 diabetes. So this slide just shows some older data on time trends in diagnosed diabetes in the US. So this study starts back in 1980, which was actually the year before I went to university. And it's only really around 95, 96 that diagnosed diabetes prevalence started to increase. So this, if you remember from the previous slide, that's a lag of about 5 years after obesity prevalence started to rise. And of course, it's no surprise that it takes a while before increasing obesity is reflected in increasing diabetes prevalence. Bringing us back to ethnicity again, I think it's really important to point out that clearly overweight and obesity are important risk factors for all groups with diabetes. But although it's bad to be overweight or obese and European, it's really bad to be overweight or obese if you're from a non-European ethnicity. Again, as many of you will be aware, there's been proposals for different obesity cut points for non-white ethnic groups, particularly Asian ethnic groups, partly because of this accelerated increase in diabetes incidence with increasing BMI, and at BMI levels that in European populations would be considered normal or healthy. One of my key areas of interest is health disparities, and I'm showing some data on this slide that a medical student has put together this year, describing the persisting and stark socioeconomic inequalities in diabetes prevalence in Scotland. So our measure of socioeconomic status is an area-based measure, the Scottish Index of Multiple Deprivation, and on the far left of the slide is the most deprived quintile of the population, and on the right the least deprived quintile. The blue dots show the higher prevalence in men than women. And what we see on the right-hand side there with the relative risks is that the impact of deprivation is greater among women. So 2.5 times the prevalence in deprived women compared to the least deprived women, and about double in for men. So our government has what they call a levelling up agenda, and I look forward to seeing how they manage to, what I hope they manage to do is level down diabetes prevalence. I'll be amazed if they do, but I look forward to seeing them trying that. I've shown you the Scottish data on the previous slide. That looks very similar, as you see, to the left-hand slide here. Interestingly, of course, in countries that are still developing, we see the opposite relationship between socioeconomic status and diabetes prevalence. This is something that we call the epidemiological transition, where initially it's the wealthy people who become overweight and develop diabetes, and then with the passage of time the pattern shifts to the one on the left hand side of the slide here. And my next slide shows some data from China, where there are two measures of socioeconomic status here: education and income. And so the bottom two graphs are for men and women, showing the effect of income on diabetes prevalence. And what we see there is increasing income is associated with increasing diabetes prevalence. Interestingly, there's a different pattern for education, where for men, increasing education in general is associated with increasing diabetes prevalence, but we don't see that pattern for women. Now, there are multiple reasons for this, one of which, of course, is that the older women in China had less opportunities for education. So it'd be really interesting to see over time whether this pattern changes. I mentioned earlier that I was interested in mental and physical comorbidity, particularly with relationship to diabetes, and what we see here is the higher risk of type 2 diabetes in people with any of the main subtypes of psychiatric illness. Particularly strong association with schizophrenia. So we haven't time to talk about all the reasons for this, but I'm sure you'll be aware that some of the newer antipsychotic drugs have metabolic consequences, and that in itself might be a contributory factor. So it might be the treatment for the disease rather than the disease itself. And I have a PhD student jointly with Caroline who led this work, who is attempting to disentangle the disease from the treatment, which I think is going to be a challenging project. I'm now moving on to diabetes complications, and keep an eye on the time. So it won't surprise you to know that diabetes is associated with increased risks of premature mortality. There's a lot of data on this slide here, and it's getting rather old now, but really what I wanted to do was to show that although overall, we can come up with estimates of the effect of diabetes on mortality, there are important differences both by sex, age, and socioeconomic status. So the relative risks for diabetes for mortality are higher for women than for men, for younger people than for older people, and higher for the more affluent group than the most deprived group. And this is a pattern where really the relative risks tend to be higher in the groups where the absolute risk is lower. This is always a challenging concept to explain, but I think if you think about it, we have higher prevalence in men than women, but there are higher relative risks for women than men for the complications of diabetes mortality in this example. This is some recently published work that Amanda and Emily and I saw presented earlier this week on changing patterns of cause of death in people with and without diabetes in the UK. And although there's lots of information on this slide here, one of the key messages is that mortality has declined overall, regardless of diabetes status. But the important difference is that cancer mortality has now overtaken cardiovascular disease mortality as the major cause of death in both people with and without diabetes. And it's an interesting debate as to whether you argue that's a success. I mean, clearly we've seen a successful reduction in cardiovascular mortality, but we've all got to die of something. And if you don't die of cardiovascular disease, the next most popular cause of death, if I can call it that, is cancer. These are data from Jessica Harding's systematic review of looking at trends over time in all-cause mortality in multiple countries. And essentially what it shows that as I showed for the UK on the previous slide, there's a good news story in that mortality rates among people with diabetes are coming down. Now, clearly, I mentioned earlier on about diagnostic criteria changing, and particularly that early diagnostic cut point where the glucose threshold dropped, then obviously you're identifying people with what you might call a less severe form of diabetes. So some of these data may not be directly comparable if the early years were based on different diagnostic criteria. Back to the US now. This is a really nice slide, I think, that shows how some of the key complications of diabetes have changed over time. And the top orange dotted slides are for myocardial infarction, heart attack, and stroke coming down over time. And amputation levels also coming down over time, and renal failure. And then at the bottom of the slide there are the acute complications, the acute metabolic complications of diabetes. So that would include ketoacidosis or hypoglycemia. I'm expanding the story with data from Scotland. This is data from my colleague Stephanie Reid, who showed that coronary heart disease deaths have, coronary heart disease risks, so this is both fatal and non-fatal disease, have declined over time. And they've roughly declined in parallel in people with and without diabetes. So actually the relative risks associated with diabetes haven't changed over that time. And we were a bit disappointed to see that. We thought some of the attempts at primary prevention of heart disease in diabetes might have narrowed the gap. But clearly, wider use of antihypertensives, statins, and also secular trends in declining smoking have benefited both people with and without diabetes, which probably explains the parallel declines. So LEA is the abbreviation for lower extremity amputation, a devastating complication, of course, of diabetes, both for individuals and their families and for healthcare. And it's reassuring to see in many countries again that lower extremity amputations have declined over time. This is likely to be multifactorial as well. Smoking is a key factor, of course, for peripheral vascular disease in people with diabetes, but also clearly better glycemic control, better management of foot disease in people with diabetes should lead to lower risk of amputations. Unfortunately, in Scotland, this is another student's work, we've seen in the last 10 years, Kirsten's in the process of updating these data. Unfortunately, we've not seen any improvement in amputation rates. We've been discussing the possible reasons for this, and one possible explanation, as I inferred before, is fortunately people aren't dying of cardiovascular disease anymore, but they are dying. They're dying at lower rates of cardiovascular disease. But if people don't die of cardiovascular disease, that opens them up to the potential for developing other complications. So in some ways, we're wondering if this is due to a survival bias. And the reason that we haven't seen a decline is because people are living longer and having more time to develop these devastating complications. And I think, talking of devastating complications, clearly end-stage renal disease is not an outcome, is an outcome to be avoided if at all possible. And this slide shows how end-stage renal disease incidence has increased among people with diabetes over time. And again, this is something that not only has major implications for individuals, but also for health services, because clearly the treatment, dialysis or transplant for people with end-stage renal disease is an extremely expensive outcome for health services. Amanda mentioned that we met at a diabetes and cancer meeting earlier this week, so I'm just going to very briefly mention the association between diabetes and cancer. Clearly, because obesity is a risk factor for diabetes and a risk factor for some cancers, the patterns that we see with diabetes and cancer tend to mirror the patterns seen with obesity and cancer. So in summary, what we see here are higher risks of colorectal cancer, breast cancer, pancreatic cancer, liver cancer, and others, such as endometrial cancer, for example, that aren't listed on this slide. And I think when we first saw that prostate cancer was inversely associated with diabetes, that came perhaps as a bit of a surprise. But again, this is consistent with the relationship between obesity and prostate cancer. This is unexplained. Clearly, screening for prostate cancer is really important, but it seems unlikely that this pattern is seen across populations and to this extent simply because as a consequence of screening. And there are biologically plausible explanations in terms of sex hormone binding globulin, testosterone levels, and so forth. And there's some evidence to suggest that although the risk is lower in men with diabetes who get prostate cancer tend to get a more aggressive form of prostate cancer. So one of the other complications of diabetes that I'm particularly interested in is non-alcoholic fatty liver disease. This is a sort of vicious cycle in terms of risk of cardiovascular disease because not only the top line of this slide here shows that people with diabetes are more likely to have non-alcoholic fatty liver disease, and then the bottom line of the slide shows that if you have non-alcoholic fatty liver disease and diabetes, you get a further increased risk in risk of cardiovascular disease. So again, this is something that's tied in with obesity. Obesity is a major risk factor for non-alcoholic fatty liver disease, which I think there's a move now to rename it metabolic fatty liver disease to just take the alcohol out of it. It's very difficult in populations, for example, in Scotland, where alcohol consumption is a sort of normal part of most people's lives, to identify this group that is purely non-alcoholic fatty liver disease. There are many people who are both overweight and who drink more alcohol than they should, and there's an interaction between obesity and alcohol and risk of fatty liver disease and cirrhosis. And I don't know if there are any hepatologists in the audience, but certainly UK hepatologists now are seeing far more people with alcohol-related liver disease. The bulk of their work used to be alcohol-related, and now the balance is shifting, and they're getting to see many more people with non-alcoholic fatty liver disease. And clearly, in some parts of the world, viral hepatitis is an important component, and there'll be many populations where people are exposed to the viral risk factors, obesity and alcohol. I'm going to try and speed up now. I mentioned mental illness as a risk factor for diabetes. Caroline and colleagues have also looked at outcomes of diabetes in people with mental illness, and it won't surprise you to hear that people with mental illness and diabetes do worse than people with diabetes but without mental illness. I'm going to briefly mention infections. This is an area that I'm planning to do more work in. Diabetes increases risk of most infections, particularly associated with TB, periodontitis, hepatitis, and HIV. And of course, with HIV, there's the issue where some of the treatments have metabolic consequences and increased risk of diabetes. I've already mentioned the interaction with viral hepatitis to increase complications of liver disease, particularly cirrhosis and hepatocellular carcinoma. And again, many of you will be aware that some of the new diabetes treatments, because they cause glycosuria, tend to increase the risk of genitourinary infections. And couldn't let 2021 pass without mentioning the association between diabetes and COVID. And again, it won't come as a surprise that people with diabetes have a higher risk of severe COVID, that is, either admitted to critical care or death from COVID, with slightly higher relative risks for people with type 1 diabetes than type 2 diabetes. My final slide is just mentioning very briefly treatments and technologies. Sulfonylurea is well-established treatment for diabetes. I heard a really interesting talk last week from somebody who's firmly believes that they should be rehabilitated, sulfonylureas, and used more widely in lower dose perhaps than conventionally. We've got a great new range of glucose lowering treatments now, and those that have cardiovascular benefits, and these of course in time will further reduce the cardiovascular consequences of type 2 diabetes. I've mentioned the other side effects, and the technology of course we really hope will make a big difference, particularly to type 1 diabetes and risk of complications. I'm going to gloss over this slide really, just because I've gone on too long, but essentially this is a really interesting paper comparing the use of technologies and inequalities between German data and the type 1 diabetes exchange in the US. And essentially what it shows is vastly wider health inequalities in the US than in Germany. And unfortunately, the fact that introducing new technologies tends to widen disparities. And I'm going to conclude now just by summarising that diabetes is increasing in prevalence, increases risk of many other conditions that I've run through. Of increasing importance in lower middle income countries, we still need better data, both on prevalence of diabetes and its complications. I've shown you evidence of persistent disparities in prevalence of diabetes and its complications by ethnicity and socioeconomic status. And as always, the conclusion is we really need to find better ways of preventing diabetes in the first place and then preventing its complications. And then I always end with an acknowledgement of my colleagues who contribute to the Scottish data. But I'm sorry for going over time. I'm going to stop there and see if there are any questions. Thank you for your time.
You actually didn't go over time at all. We have plenty of time for questions, so very, very efficient. We so far have one question in the chat, and I invite everyone to add their questions or to raise their hands. So the first one is from Dr. Elliot Rayfield. He says, excellent overview, thank you. And can you explain the decreased incidence of necrobiosis lipoidica diabeticorum, hopefully I said that correctly, in type 1 patients with type 1 diabetes over the past 20 years?
The short answer to that is no, I can't. I mean, I remember seeing it as a clinician, but I because I've not been practicing in recent years, I hadn't realised that was a declining complication. I wonder, I like to try and attribute lots of things to declines in smoking. I'd be really interested to know whether smoking is a risk factor for necrobiosis. Maybe the person who asked the question could chip in there. Or anybody else who knows.
I don't know. I don't know. That's why I asked the question.
Okay, yes. No. Well, it's a technique I've learned is to, for questions I don't know the answer to, is to return it and see if I can gain something new from it. So is smoking a risk factor for necrobiosis, do you know? No, it's no, it's just one of those anecdotes. The person I can think of that I saw a particularly severe case in was a smoker. So I'm putting 2 and 2 together and making 5.
Okay, so our next question is from Emily Gallagher. Do you have any theory on the high prevalence of type 1 diabetes in Saudi Arabia? Is it really type 1, or is it people who are just younger and on insulin who are being classified as type 1?
I think I may have to take a rain check on that, Emily, because I know very little about it. But I've got a PhD student starting in September who's going to use the Saudi Arabian Diabetes Registry. So I'll attempt to come back to you on that. It's really interesting. I mean, as I understand it, it really does look like type 1 diabetes, rather than severe type 2 needing treating with insulin. But why that would be is hard to know. I mean, I think you have to tread a bit carefully with some of these things, but there's a higher level of consanguinity in some populations. But I'm not sure if that's particularly relevant in this case. So I shall try and remember to tell you if I discover any more.
Okay. Following question is from Alice Levine. And how do you reconcile the decreased incidence in some countries of diabetes with a predicted rise in the prevalence worldwide?
Well, I think, again, it's a combination of factors. Prevalence reflects both incidence and mortality. So I think in some countries, both incidence and prevalence are rising, but in other countries, incidence is declining, but prevalence is increasing because of increasing survival. But I think, in terms of the people in the audience who are diabetologists, diabetes isn't going away fast anytime soon in any country. I don't think there'll only be increasing numbers of people with diabetes and increasing numbers of people with complications of diabetes who need care.
Okay. Question from Zachary Bloomgarden. Could you comment on the on the relationship between physical activity and diabetes, and then on the flip side of that, the relationship with diabetes and sleep?
Oh yeah, very interesting. I mean, I think there's increasing evidence about sleep. Physical activity, clearly, one of the reasons why we see increasing prevalence of obesity is because we live in an obesogenic environment. We're far less active than our ancestors were. Physical activity is a really important factor for maintaining weight and risk as a risk factor for diabetes. There's some interesting data from my colleagues who've looked at physical activity by ethnicity, and it seems as though people from South Asian backgrounds, so India, Pakistan, Bangladesh, need to do more physical activity to lower their risk of diabetes than European populations. But that's speculative. I think we all should be more physically active than we are, and that is related to sleep. I think the more physically active you are, the better you sleep. And I think the association between diabetes and sleep is one of these vicious cycles where poor sleep, we know people who work shift patterns tend to be overweight because of poor eating habits and less physical activity, and then are more likely to develop diabetes. And then a complication of diabetes that I didn't mention was sleep apnea, which obviously then has a vicious side effect. If you've got sleep apnea, you don't sleep well, you probably eat more or drink more to stay awake, drink more coffee during the day. So really interesting, I think, and really interesting from a public health point of view about how you get people to sleep more. We probably all realise we should sleep more, but we can't somehow fit it into our busy lives.
And next question is from Nina Bakel. So if obesity is associated with increasing insulin resistance, why do you think that diabetes is decreasing while obesity is increasing?
I wish I knew that. I mean, I really hope there'd be somebody who could offer a solution to this. I don't think anybody quite understands why this would be. I mean, there have been various hypotheses, and maybe there's a certain proportion of the population who are susceptible to developing diabetes with obesity, and that we've sort of exhausted that subgroup of the population, and the people who are getting obese now are resistant. I think that's highly speculative. Really difficult to know why that would be, and it's a complex relationship. I mean, the mention of physical activity before is that maybe you can be fat and fit. Many of you will have heard of Steve Blair, an epidemiologist in the US, who is a firm proponent of the fact that if you had to choose between being fat or fit, or the combinations of fatness and the two by two table of fat and unfit, it's better to be fat and fit than to be thin and unfit. So maybe the people who are adding to the obesity prevalence now are still maintaining their physical activity levels and protecting themselves against diabetes. Again, that's entirely speculative.
So further question from Emily Gallagher. Could you comment further on the phenotype of the malnutrition type of diabetes in Rwanda? Do you think it's an inflammatory type of insulin resistance, such as cachexia or sarcopenia?
Good question, Emily. I don't know. I mean, there's plenty more work to be done there. I mean, it's really interesting. The people, my PhD student Charlotte's patient, she's an adult diabetologist in Rwanda. She describes their onset of diabetes in middle age, by which she means 20 to 30. It's a different definition of middle age in Rwanda. But so most of her patients are diagnosed either in their late teens or early 20s, and tend to have had this history of childhood malnutrition. So there's really interesting developmental origins of adult disease, and so it's possible that people in that situation have a decreased beta cell reserve, and the first episode of this sort of ketosis tends to occur in association with an acute illness. So a bit like I mentioned, the sort of stress of pregnancy, stress of having an acute illness, usually an infection, tips people into ketosis. They're really sick, need treating with insulin, but then as they recover from the acute illness, the insulin can be stopped, and the difficulty is it's not well described, and there are very few guidelines. So it's a real problem for people treating people like this. And I know there are cases described in the US as well, particularly amongst African Americans. So I think the knowledge about how to manage people in this situation is different, but clearly more information needed. And there may well be, because they haven't been able to measure antibodies or C-peptide, they just don't have the resources to do that. There's the possibility, of course, that the prevalence of some of those rarer subtypes of diabetes is higher in these populations. But Charlotte's view is very much that it's related to this long-standing malnutrition, and just because there are people the people in Rwanda are thin. This is not obesity related at all. So it seems to be more of a beta cell problem than insulin resistance.
Question from Amanda. So any ideas on why higher income can be associated with the increased diabetes complications and mortality in the Scottish data? It's an unexpected finding.
So actually, sorry, I probably had that the other way around. So it's lower socioeconomic status is worse. So it's all confounded with smoking and so forth. So both prevalence and mortality in Scottish data are associated with higher deprivation, lower socioeconomic status. I can sometimes get my highs and lowers muddled. Sorry about that.
And I think we'll finish up with our probably most challenging question from another one from Elliot Rayfield. What can be done to better regulate the food industries with the addition of sweeteners and preservatives?
Oh, good. Well done, Elliot. That's a nice, easy one to end on. I think it's really difficult. I mean, it's fascinating to watch what's happening in Mexico, isn't it? There was much discussion about their sugar tax on their drinks. There seems to be good evidence that's working. Certainly in Scotland, there's been discussion about sugar taxes. And I think Denmark also managed to restrict their trans fats. But I think they've had to rescind that now because of pressures from the industry. And I think that probably comes back to it, that there are so many vested interests that it's really difficult for public health and clinicians to compensate against that. And I think we're really battling the fact that in an obesogenic environment, when people are a bit miserable, it's too easy, isn't it, to reach for a high fat, high sugar snack rather than something that's healthy. But and I think governments are really mixed about how much they want to do because of these vested commercial interests. So we've got to keep trying. It's not going to be easy.
Great. So we're just at about time. Thank you so much for a great talk. And have a good rest of the day.
Thank you very much. Great to see you all. Bye.